Hello everyone, so I'm back with the third part of breast cancer. In this part, we are going to be talking about management. So now the patient is being diagnosed with breast cancer, and now we have to move towards management. So surgery is the mainstay of treatment for most patients, and this can range from lobectomy, where only the tumor is being removed, to mastectomy, where the whole breast is being removed. Lymph node sampling is performed at the time of surgery. Uh, Adjuvant radiotherapy is given to reduce the risk of local reoccurrence to 4 to 6%. So, radiotherapy is given after this surgical procedure to reduce the risk of reoccurrence. So, uh, reoccurrence risk is being reduced up to 4 to 6% by radiotherapy, and hormonal therapy can also be given to reduce the risk of reoccurrence. So it also improves disease free and overall survival in pre and post menopausal patients who have tumors that express ER, that is uh, estrogen receptors. They are estrogen receptor positive tumors. So in those kind of tumors, we provide hormonal therapy to reduce the risk of reoccurrence. Patient at low risk with tumor that are small and ER positive only require adjuvant hormonal therapy with uh, tamoxifen. So this drug is actually as selective estrogen receptor modulator. We will discuss its diagram in our next slides. So how it actually performs its action, it actually binds to estrogen receptor and thereby blocking the proliferative action of estrogen on mammary epithelial. Patients with tumor that are ER positive and who are premenopausal should receive an LH RH agonist, that is such as goserelin. So these kind of drugs which are LHRH agonists. How they actually work? They actually suppress the synthesis of estrogen from ovaries. So what it will do, it will decrease the further reoccurrence of cancer. So chemotherapy, adjuvant chemotherapy can also be considered for patient at higher risk of reoccurrence. If a patient has more chances that will have reoccurrence of cancer in future, so we can provide chemotherapy to that patient. Factors that increase the risk of recurrence include a tumor of greater than 1 centimeter, tumor that is ER negative, or the presence of involved auxiliary lymph node. If there are presence of swollen lymph nodes in axilla, that is armpit, so there are increased chances that she may have reoccurrence in future, and that patient is more likely to have reoccurrence. So in those kind of patients, we can give chemotherapy. So such patients should be offered chemotherapy so that we could improve their survival. So there are a number of tried and true chemotherapy regimens used to treat breast cancer, including AC, that is um, adriamycin, and cyclophosphamide. Now these the things, the names which are being enclosed in brackets are actually brand name of the drug that is actually written. So doxorubicin is actually brand name of adriamycin. So EC is epirubicin and cyclophosphamide, and CMF, that is cyclophosphamide, methotrexate, and fluorouracil. AC, that is adriamycin and cyclophosphamide. These can be followed by paclitaxel, or docetaxel. And docetaxel concurrent with AC. So it may be followed by that, or it can be given along with AC. Okay, 5-uracil, fluorouracil, epirubicin, rubicin, and cyclophosphamide. That is, this all makes FEC, and this can be given with doxytaxel or paclitaxel. So we can name it as FEC doxytaxel, FEC paclitaxel. So these are actually different regimens which can be given as chemotherapy. So over here, there is an example of a chemotherapy regimen, that is FECT. So why it is written T? Because of the brand name of doxytaxel. So doxytaxel has its brand name as taxotere, which is having doxytaxel as a drug. So that's why it is denoted as T. So if we are using this regimen, uh, its indication is adjuvant breast cancer, and length of the cycle would be 21 days, and number of cycles would be 3 of FEC, followed by 3 cycles of doxycytidine, which is drug having doxytaxel. So now FEC, that is fluorouracil, uh, epirubicin, and cyclophosphamide. Now these three drugs are given in IV bolus form. IVB means IV bolus, and their dosage is being written over here. And T, that is having doxytaxel, will be given in the form of IV infusion over 1 hour. So this will be given in the form of infusion for um, over 1 hour, and dosage is also being given over here. So metastatic disease management include radiotherapy to palliate painful bone metastasis, and second line endocrine therapy with aromatase inhibitors. Aromatase inhibitors stop the production of estrogen in postmenopausal women. So actually, we know that estrogen can be the risk factor for um, further worsening of the cancer. So we are actually giving these things to reduce the production of estrogen. Aromatase inhibitors work by blocking the enzyme aromatase, which convert the hormone androgen into estrogen. So androgen is being converted into estrogen by this enzyme, and we are going to inhibit this enzyme. So when we are going to inhibit this enzyme, what will actually happen, that there will be no more conversion of androgen into estrogen, and now there will be no more estrogen in the body. So this is how it works, and these inhibitors include anastrozole and oxymestane and letrozole. And now these three are categorized as aromatase inhibitors. So over here we have uh, names of the drugs, medications, and in brackets we have mentioned their brand names, and they how they act or how they perform their mechanism. For first three, as we discussed previously in previous slide, that these three are aromatase inhibitors, whereas tamoxifen citrate, so this drug is selective estrogen receptor modulator. We also have mentioned this drug previously. So these are different mechanism of action by which these drugs actually perform their action in reducing estrogen in the body. So anastrozole is a drug which act by um aromatase inhibitory action, and it is given 1 milligram orally daily, and exemestane is also showing its mechanism of action by aromatase inhibition, and it is given 25 milligram orally daily. And letrozole is also working by uh, aromatase inhibition, and it is given 2.5 milligram orally daily. And the next, that is tamoxifen citrate. It acts by selective estrogen receptor modulatory effect. So this drug actually is given in 20 milligram orally daily. And now if we talk about their side effect, there is hot flushes, skin rashes, nausea, vomiting, bone loss, or there could be um, some joint pain or muscle pain, that is myalgia, or there can be some kind of rashes or uterine bleeding or thrombophlebitis. So these are the major side effects. Now, most patients with HER2 positive tumors should receive trastuzumab containing chemotherapy regimens. And trastuzumab is actually a humanized monoclonal antibodies to HER2, and it works by attaching itself to HER2 receptors on the surface of breast cancer cells and blocking them from receiving growth signals. So now we are having no more growth signals, so there will be no more growth of cancer cells. And by blocking this signal, trastuzumab can slow or stop the growth of breast cancer. So now over here, we have this diagram that shows that uh, when there is this testosterone, this is being converted into uh, estradiol by the action of this enzyme aromatase. And now over here we have uh, stenedione, which is being converted into estrone by the action of the same enzyme, that is aromatase. Now, as we know, we are giving drugs which are actually aromatase inhibitors. Now, these enzymes which will actually inhibit these inhibitors will actually inhibit these enzymes. Now, when there will be no more action of these enzymes, there will be no more conversion of these things into estradiol. When there will be no more presence of estradiol in the breast cancer cell, there will be no more attachment of estradiol to estrogen receptor. And when we will have no more estradiol attached to estrogen receptor, there will be no more functioning of estrogen um, associated with growth of breast cancer cells. So this could be the one way to decrease the estrogen action on breast cancer cells. The other way is uh, by the action of drugs which are selective estrogen receptor modulators like uh, tamoxifen. Now, this drug, tamoxifen, will actually bind to the receptor and will not allow estradiol to attach to estrogen receptor. Now, it will actually block the binding of estradiol to the estrogen receptor. Why? Because it is itself binding to that receptor and not allowing the growth or functioning of estrogen after being attached to the estrogen receptor. So this is how the both categories of these drugs perform their action in decreasing the functioning of estrogen on breast cancer cells.